Welcome to CFRI's Cystic Fibrosis Community Voices, a video podcast series created by and for the cystic fibrosis community.
Everyone knows who you are. Where your fame.
So for artificial pancreas, again, as I mentioned before, that we will come to the part of the talk where we will be combining the glucose monitoring devices with the pump technology, and to see how we can kind of merge those two together, again, to make life easier for the patients and to actually use it as one system. So the less patient interaction or the less brain required to be used for that, because it is very demanding disease, and it takes a lot of burden and a lot of thinking, a lot of pressure, and it's just a 24/7 condition. So the more we can do to try to relieve this pressure, the better that would be. So this is a roadmap for to artificial pancreas that Aaron Kowalski created. So I'll show you where are we in this roadmap now. So initially was this first step when the pump was connected to the sensor. If the sensor senses that glucose reached to low threshold, whichever we set it up for, could it be 60 milligram per deciliter or 80 milligram per deciliter, the pump will shut off itself. Let's say if you're sleeping and you're not feeling your low blood sugar and you do not hear the alarms, and unfortunately we know from the studies in type 1 individuals that less than a third of type 1 individuals hear their alarms, and most of the low blood sugars are actually missed during the night. So the pump will shut off, and then it would restart itself in 2 hours. So that was the first step, and we have still those pumps, and they're still being used. The next step is the hypoglycemia minimizer. So what that is the pump will predict, with the help of the sensor in the algorithm that's programmed in the pump, to determine depending on the rate of drop of the blood sugar, when the blood sugar is predicted to be low. And the pump will stop the insulin, doesn't let the patient to get too low blood sugar. It's not 100% prevention, but it does do a good job. So it will stop the insulin delivery before hitting the low, and then it will restart the insulin delivery when it reaches above the threshold that we set it up for. The next step is hypoglycemia and hyperglycemia minimizer. So it's not only treating or correcting the low blood sugars, but it also adds extra insulin if blood sugars are going high. Then we are at the closed loop or hybrid closed loop. So that's where we are right now at this stage, where with the Medtronic insulin pump, when again it's assist patient with both bolus calculation, plus it adds the insulin if the blood sugar going high after meals or overnight. We're hoping that we will get soon to this fully automated closed loop system when the meal time would be determined by the pump, and patients would not need to calculate the carbohydrates, would not need to enter carbohydrates. There is a study ongoing where there is a accelerometer in the Apple Watch, and it determines what kind of movement you do with the Apple Watch. And if you do this repetitive movement, it assumes that you are eating, and it starts delivering the insulin. So the study is ongoing now, and we'll see where we'll get with that. And then we will get to fully automated system, because it's usually not just the insulin delivery issue. There's other hormones involved in the glucose regulation, such as glucagon and amylin and some others. So it could be a multi-hormonal system that will deliver not just one insulin, but different hormones as well to help with the glucose control. So what do we need? What kind of components do we need to have this system? So we need an accurate sensor or continuous glucose monitoring device. We need a receiver that quickly receives this device and via the Bluetooth it sends it to the receiver that analyzes the data. It analyzes the data, not only what this number is, but with the rate of change of the glucose, where it's going. Is it going up or down, and predicts what will happen in whatever period of time, 30 minutes usually. And then it sends the information to the, so the algorithm calculates it, it sends the information to the algorithm decides how much insulin to deliver, send it to the pump, and pump delivers that amount of insulin. So as we mentioned before, there are some delays, and that's where our challenges are, that unfortunately the insulin that we give is not the human insulin. So it does the onset of action of our insulin within minutes, the onset 2 to 3 minutes. The onset of action of the insulin that's being injected is about 20 minutes or 15-20 minutes at least. When we produce insulin from the pancreas, about half of that goes straight to the liver, and it suppresses liver production of extra glucose. When we infuse insulin or inject insulin subcutaneously, it takes about 100 minutes for that insulin to reach the liver. So as you can see, it's not a perfect system, and therefore those are the challenges that we're having to actually create the fully automated system. So this is the hybrid closed loop device that's currently available. This is the actual real picture of one of my patients. So you can see the little pink marks are the boluses, that microboluses that we call them, that insulin is delivered overnight when the patient is sleeping. So you can see patient is sleeping, the insulin gets delivered. So here patient just started going down, the insulin delivery got stopped, then started going up, the insulin delivery resumed. So the pump is smart. You can see the blood sugars is going up here. The pump started delivering more insulin. The orange is how many carbs the patient ate, and the blue ones is how much insulin the patient boluses delivered for the meals. So again, you can see that the nights are pretty flat. The nights usually when we don't eat, the pump is working really well. So when we eat, the challenges are in the accurate carb count, delivery of the insulin on time before the meal. So those are all the challenges. But when patient's sleeping, and you can see the blood sugar going up, probably some residual absorption from the meal, but pump kicks in, delivers more insulin, and blood sugar starts coming down. So it's a very smart device, and you can see that before patient used the green bar is how much, what's the percentage of time blood sugars were in target before using the closed loop. And this bar with the A, it's almost double the amount of percentage of time being in target with the use of the closed loop. And you can see that the peach color, or whatever color, orange color, is the color that before the closed loop, and you can see how nicely flattened and the numbers came down with the use of the closed loop system. Again, this is real-time data from one of the patients. This is, remember I told you that they're not just insulin regulates the glucose, but there are other hormones such as glucagon. So this is the bihormonal bionic pancreas that is, the studies are ongoing, and we're starting the study here at Stanford doing currently. So it delivers glucagon and insulin. So previously, that's the initial study. So you can see how much equipment patient had to carry. So they had 2 pumps. One was with insulin, one was with glucagon. They did have 2 insertion sites. They had a continuous glucose monitoring device. They had to have the transmitter with them, and that all will go into the phone. And the phone used the algorithm that would send the information to either one of the pumps. So if glucose levels were going down, it will send the signal to the glucagon pump, and the glucagon boluses will get delivered. If sugars were going up, it will send the information to the insulin pump, and the insulin will start being delivered. So this actually works really well, and we're having this 2 pumps combined in one. So there's a new device that's called iLED. It's created in Boston by Dr. Edward Damiano, and he hopes to get this approved by probably 2020 or so. So again, we're starting the study with this device. This one we already finished back in a few years ago, and now it's the new device that he has. So going from, if some people are not feeling comfortable wearing the devices, because this device is attached to you 24/7, and this is, for some people it's bothersome, and it's, you have to be kind of reminding you that you do have diabetes 24/7. Some people are not comfortable with that. So we're hoping to get those smart pen devices that will have a calculator in the pen, similar to the calculator what I showed you in the pumps. And luckily we do have such a device available. It's FDA approved. It's called the InPen. It's made by the company that's called Companion. They're located in San Diego. So as you can see, the pens come, that's kind of different faces or different sticker that you can put on the pen, and this is how it looks without any sticker. So they come in 3 different colors. It delivers up to 30 units with half a unit increments, and it communicates wirelessly with the app on the phone, with the application of the phone, and the application of the phone pretty much works as your pump calculator. So it has the same kind of settings that we talked about in the pump calculator. So you put the amount of carbohydrates, it calculates how much active insulin still in the body. As you can see on the screen, it shows you that you have IOB, which stands for insulin on board, so you would not overcorrect yourself. It shows you what your blood glucose reading was, when was the last dose of insulin, and how many units and what was delivered over some period of time. It's really useful for us as a healthcare providers, because a lot of the times when we're seeing blinded numbers either on CGM or continuous glucose monitoring or on the meter, we don't know how much insulin was given, and we don't know what caused what caused the higher blood sugar, what caused the low blood sugar. With this one, it has pretty nice reports, and it gives you the information of when and how much insulin was given. So how do we use this technology in CF-related diabetes, and why we're underutilizing this technology? So there are some factors that complicate the management. It's exocrine insufficiency, meaning that insufficient production of the enzyme that creates variable degree of malabsorption of the food. The gastrointestinal dysmotility, so there could be gastroparesis or other issues with the gastric emptying with unpredictable food absorption. There are chronic infections, exacerbations with changing of the insulin sensitivity, being more insulin resistance during the time of the exacerbation, and being more insulin sensitive when coming off the steroids, for example, or meals. So we're usually, if for our type 2 patients, we're saying that try to restrict your carbohydrates. And cystic fibrosis individuals, we're encouraging not to restrict carbohydrates. So usually carb meals are pretty high, and they're high caloric requirements, higher than in any other type of diabetes. So there's not too many studies, unfortunately, of the use of the technology in CF-related diabetes, and some of the studies are just as a case reports. So one study used CGM in cystic fibrosis patient to try to predict pulmonary exacerbation. So they used Dexcom, the one that I showed you before, G4, the older version, and they used it unmasked, meaning the real time, for 3 months, and they recorded during these 3 months the pulmonary exacerbations, and they looked at the blood sugar readings overnight, fasting, and pre and post breakfast, and post each meal, and you can see that this week before exacerbation, at all time points, the blood sugars were higher. So the suggestion was that could that device predict that something is coming? And what we usually tell patients, that if you do see unexplained rise in the blood sugars, it's probably not just the blood sugars, it's probably something is coming. Something is, either you're getting sick, or so the blood sugar is usually as a barometer, so it shows ahead of time that something is going to happen. So this is the case report of, it stands for SAG, stands for sensor augmented insulin delivery, insulin pump in patients with cystic fibrosis related diabetes with significant improvement in flattening of the diabetes control. So you can see it's pretty flat and nice even with the high carb meals with the use of the pump. So what are the benefits of insulin pump in cystic fibrosis related diabetes? So its ability to give glucose, the bolus with every meal and snack. It eliminates the need for the injection. So you wear this pump again, usually the infusion sets for 3 days, and you are just pushing the buttons, not needed to take a shot. If you're out, if you're with friends and at the restaurant, you don't have to run to the bathroom to give yourself a shot. You can underneath the table or just using some sort of device. Everyone uses iPods and no one really asks you what that is. You can just put the button or push the button and deliver insulin. So it had been shown that it helps with increased weight, increase in the lean body mass, improve hemoglobin A1C, improve fasting glucose. All of those were statistically significant. It improved the 2-hour postprandial glucose, and it did increase a little bit the insulin delivery, obviously because it controlled the sugars better. So why insulin pump therapy is rarely used in cystic fibrosis related diabetes? The data from German-Austrian registry showed that they looked at 515 patients with cystic fibrosis related diabetes and over 43,000 patients with type 1 related diabetes. So discontinuation of the pump was way higher in CF-related diabetes than in type 1 related diabetes. What are the possible explanations of that? Is possibly rapidly changing insulin requirements, decrease requirements to low levels after exacerbations, really low insulin requirements. It is time consuming. Patients need a lot of breathing treatments. It's an extra device to take care of. Not being able to handle the pump in addition to, again, other pulmonary therapies. Pulmonologists not being familiar with what the pump is, not being comfortable with managing the pump, and cost, and very unfortunately the insurance coverage. So we are getting a lot of issues with the insurance coverage. So the private insurance is usually fairly easy to get approval from, but Medicare, Medi-Cal, only approving the devices for type 1 individuals, that is showing that the insulin production is extremely low. We have to show that data, or if it's autoimmune diabetes with presence of antibodies, or we have to write multiple appeal letters. Sometimes we're successful, sometimes we're not, but private insurance are pretty generous. No severe hypoglycemia had been documented with the use of the pumps. And this was, again, the largest study with the use of the pumps in cystic fibrosis related diabetes, but it included only 21 patients. So we don't have enough data to use for more extrapolate to the whole CF population. Can we use continuous glucose monitoring therapy to identify patients who are at risk for development of cystic fibrosis related diabetes? Again, as I mentioned early in my talk, that from the CF Foundation registry, only 28% of adults were actually tested for with oral glucose tolerance test for diabetes. So a lot of the individuals being undiagnosed until presenting with pulmonary exacerbation and with high blood sugar. So does abnormal continuous glucose monitoring device predict future health outcomes in adult patients with CFRD? So the study was done looking at the abnormal association of continuous glucose monitoring with the development of CFRD, looked at the lung function and the decline of the body mass index of increased rate of pulmonary exacerbations. So they did simultaneous 75 gram of glucose, 1 and 2 hour measurements post 75 gram of glucose consumption, and compared with 3 days of continuous glucose monitoring use. They looked at the follow-up in 5 years, and they looked at the baseline body mass index. They looked at the baseline forced expiratory volume at 1 minute, used as the highest recorded value in 1 year prior to the study. And full data was available, again, only on 18 patients. 3 patients had the same results, matching from OGTT and CGM. But some patients had a greater impairment of on oral glucose tolerance test at 2 hours. But there was a strong correlation of the between OGTT at 1 hour and CGM elevation, and the correlation coefficient was 0.77. So CGM results were not associated with decline in lung function or BMI or increased rate of pulmonary exacerbation over 5 years of the study. But again, that was a very small study. But looking at abnormal CGM, if we pick the numbers over 200 on 2 dates by continuous glucose monitoring device, it's identified some more individuals who would develop CFRD comparing to the ones who only identified by the 2 hour on the glucose monitoring test, on the OGTT. So sensitivity and negative predictive value test of continuous glucose monitoring was similar to 1 hour OGTT, but both OGTT at 2 hours and CGM were better than either test alone. So the conclusion was that either test can provide better prediction of CFRD than the traditional test or this 2 hour test. So again, it's 1 hour OGTT better predicted who will develop it, or a continuous glucose monitoring device. But traditional OGTT, we do measure both 1 and 2 hours usually. The 1 hour, if the sugar is elevated, we call it indeterminate glycemia, so it's not caused as diabetes yet. And we do know that that's associated with further increased risk of development diabetes, but whether that needs to be treated early enough, we don't know. We don't have this data. And as we mentioned before, there is a term as diabetes burnout because it is what is the definition of it. It's a collection of the feeling and behavior that occur after taking care of diabetes over and over and over again without the break for 24/7. So we're hoping that all those devices will help us to make life easier and to take the burden off the patients.